Okay, good morning, everybody, and welcome. Good morning. I'm Cara Carter. I'm the Senior Vice President for Strategy and Programs at the California Healthcare Foundation. I am delighted to be here with all of you, and I'm really excited about the topic for the day. So the California Healthcare Foundation is an independent nonprofit philanthropy. We are dedicated to a mission of improving healthcare for all Californians, with a particular focus on those with lower incomes. Our headquarters is in Oakland. We have an office here in Sacramento, but our work is really statewide, so really spans the breadth of the state. So today's convening is one in a regular series of Sacramento briefings that the foundation holds. We sponsor these for Sacramento policy staff and other folks that are interested. They have really two core objectives. So the first is to bring you information that is relevant, recent, important to the key healthcare issues and trends that we see across the state today. And the second is to promote dialogue and conversation on possible solutions to the challenges we face as Californians. So today's briefing is about behavioral health integration in Medi-Cal. It is a companion briefing to a briefing we held last September about the public mental health system in California. If you missed the first one, don't worry. It's on our website, so you can see it there. Today's briefing will also be available on our website for folks who've missed it. And I would point out that although this room is very packed and very full, we are a small fraction of the folks that are listening to the conversation today. So we are joined by over 500 people who registered via live webcast or telephone. I see that as evidence of the great interest and commitment from all over California to the topic. So last week, CHCF released its second annual California Health Policy Survey. And I'd love to point out that for the second year running, the top health priority that Californians cited when asked was to make sure people with mental health problems get treatment. More than half of respondents to the survey said this was extremely important to them. Californians also made it clear in the poll that they support the integration of behavioral and physical health. So strong majorities said that they wanted their primary care provider to know if they had a mental health or a substance use problem. 9 in 10 respondents want to give local communities more tools to connect homeless people with mental health care. And finally, similar numbers to that think that every Californian with a serious mental illness should be able to turn to a single care team when they're looking for treatment or help. It's this issue of integration that we're going to explore with you today. So integration has been a big theme in the state, not just in our survey, not just with providers, but also we've seen it crop up as high profile as a theme in the Department for Healthcare Services, Medi-Cal Healthy California for All initiative. And I just want to commend DHCS for really taking on some long-standing systemic problems, including modernizing how the state pays for behavioral health in Medi-Cal. I'm excited to see counties, providers, advocates, and consumers all working with DHCS on this to make improvements in the system that we have today. And at CHCF, we're proud to be part of that work. And we're proud today to be able to bring a panel of very distinguished speakers to help talk about both the national landscape for behavioral health and physical health integration in Medicaid, as well as what's happening here on the state. So we'll talk about a local perspective on integration and partnerships between counties and plans today. So my colleague, Catherine Tier, is going to be our MC for the day, and she's going to introduce our speakers shortly. But before we do that, we want to root all conversation we have on behavioral health and Medi-Cal with the experience of people who receive care. So our first speaker will be Alice Washington. Alice is an associate at the California Institute for Behavioral Health Solutions, and she was part of the group that helped CHCF and the Wellbeing Trust create the blueprint for integration that we published last year. So Alice is going to start us off with her experience as a consumer, and I ask you to join me in welcoming Alice to the podium.
Make sure this is up. Hello, and thank you for allowing me to present with you today. As a person with lived experience and an associate at the California Institute for Behavioral Health Solutions, I offer this testimony with the California Healthcare Foundation today about integration. Lack of integrated care results in bad outcomes. I was in college, employed, and living at home, but in my late 20s, I was placed in an inpatient unit for a serious mental health break. I was disabled and could not work in the community. I was approved to receive Medi-Cal and Social Security benefits, SSI. It was not easy getting these benefits. Even though I was quite ill, I still had to jump through hoops to get them. At that time, the goals of both were to rehabilitate me so I could once again be fully and gainfully employed. This happened over time, but the rehabilitation was not integrated care, as I was receiving treatment for mental illness only. The treatment was not coordinated with physical health care. Physical health care fell off the radar. One very bad outcome of this type of uncoordinated care was my becoming morbidly obese, which later led to diabetes. Every provider and peer helped me. Peers are people who give back and tell their stories. People use their lived experience to improve the system because they have valuable insight for policymakers and providers. After living through the same issue, peers are helping others, and peers have added value for all. All who were involved with me held hope for me until I could hold it for myself. And that quote is from Dr. Rick Gosha, who's our Senior Vice President at CIBHSS. Fast forward to 2010. While working at CIBHS, we began to talk about integrated care. The conversation started because the NIMH KDA schizophrenia study showed that psychotropic medications were causing physical health issues for mental health clients who were taking them. At that time, I learned my Zyprexa had also contributed to my diabetes. So it was imperative that we begin to look at treating the brain with the body. My quest and advocacy after that, and now dealing with mental health remission and physical health issues, was to help the public behavioral health system help all Medi-Cal recipients not have their behavioral health and physical health issues treated separately. Why was the brain being treated separately from the body when that major organ is directing the entire body? For instance, diabetes can be impacted by stress and anxiety. Stress and anxiety are manifested in the brain, but diabetes affects the entire body because of high blood sugar levels due to lack of insulin from the liver. So how can you separate the brain from the body as blood flows through the entire body? Is there a cure? Many years ago, during 1991, mental health realignment happened because the state faced an unprecedented funding shortfall, and we were dealing with declining public mental health budgets. The late Dr. Sandra Naylor Goodwin worked with former Assembly member Bruce Bronson on this legislation. But I later learned after her passing, which was last year, that one legislator asked in a hearing, "Why should we fund mental health treatment when there is no cure?" In 2019, I was sad and hopeless upon learning this had happened. Based on lived experience from clients and research, we have learned a lot over the last 30 years. The concept of having a cure for mental health, substance use disorders, and diabetes is a misnomer, is problematic, and may be impossible. Why? Human beings are always learning, growing, and evolving with every passing day. Our health and lives, whether lived or researched, gives us opportunities to discover, grow, change, and recover to a place of wellness. Because of this, no one can be perfectly healthy or cured, but we can recover to a place of feeling well. Integrated care keeps me alive today. That's my quote. I moved from the public mental health system of care when I was ready for full-time employment. I remember the transition I made, leaving permanent supportive housing to my own apartment in Sacramento, California. And this is important. I remember talking to the Social Security Administration as they questioned me if I was ready to go back to work. I don't know if they cared, but they questioned me. Take this even further, During this process, I began receiving integrated care from an HMO. This happened because I switched to private health care benefits. The HMO has teams that require a hub where all talk and make treatment decisions about the whole body. This was my first experience with integrated care. Their ability to talk with each other and understand the workings and treatment of the entire body helped me understand how to do self-care better, both for mental health and physical health. Today, I am managing my nutrition and am mindful of the need to exercise and participate in mindful activity. Finally, because of my lived journey, I know integrated care fosters recovery-based services. Both public behavioral health and private health care insurance systems should include certified peer support and housing first and employment first models that were used when I was on Medi-Cal and SSI. I am a work in progress, much like a puzzle. See the puzzle up there? This is just random. And then I have it on me. I am a work in progress, much like a puzzle that needs all pieces put together to complete the entire piece of artwork. Thank you for allowing me to tell my story of hope and recovery.
Thank you so much, Alice. I'm Catherine Tier. I'm the Associate Director of the High Value Care Program at the California Healthcare Foundation, and again want to welcome you all in the room and online. It's my privilege to be here today with so many wise colleagues and to serve as the MC for this briefing. I'm not going to talk very long, but I do want to explain what we plan to cover over the next hour or so and provide some context for today's conversations. As Alice said, mental illnesses and substance use disorders, and we're going to refer to them together here as behavioral health, are common, chronic, recurring, often serious conditions. And, as Alice also said, they can be treated and managed. And they're best treated in an integrated manner, where behavioral health care and physical health care are systematically coordinated. According to the Substance Abuse and Mental Health Services Administration, integrating mental health, substance abuse, and primary care services produces the best outcomes and proves the most effective approach to caring for people with multiple health care needs. And I think that is no longer in question, but is really a given for what we're talking about today. So our goal here today is to provide some context as conversations swirl around achieving integration in Medi-Cal between physical and behavioral health services. We're going to talk about what that means, what it looks like in other states that are in the process of taking this same journey toward integration, and also what counties and plans here in California are already doing and planning to do to meet the needs of their consumers. There. So here's the agenda for the rest of the morning. I'm going to do some level setting, as I said, and then we will hear from Alison Hamlin from the Center for Healthcare Strategies about what they've learned about pathways to success for state Medicaid programs that are pursuing integration. After Alison speaks, we'll turn to a panel of California experts from plans and counties who will each speak about what they're doing. We will have time for questions and answers and discussion at the end. Those of you in the room have cards on which you can write questions. We'll collect those along the way. Those of you online, there is a box on the screen where you can submit questions, and we will get to as many of them as we can. So most of you in this audience are very familiar with the way California's Medi-Cal benefit is split among three systems. I've called it divided here, but we also hear the terms bifurcated and even trifurcated. And this diagram shows generally how it works for the 80+% of California's 13 million Medi-Cal enrollees who are in managed care arrangements. So moving counterclockwise from the green bar at the top, managed care plans manage physical health care and a limited set of mental health services. County mental health plans manage a more expansive set of specialty mental health services. That's the teal color on the bottom left. And then counties also manage substance use disorder services under drug Medi-Cal, either through the traditional fee-for-service program or increasingly, now in 30 counties, through the drug Medi-Cal organized delivery system, which is a separate managed care plan just for SUD services established a few years ago under our current waiver. And while there are some requirements for coordination among these three systems, they are not very strong. Billing and payment, data and reporting, and accountability in the three systems don't line up in all cases, despite the best efforts of providers and administrators to make these systems work together. Care coordination is extremely challenging under this siloed system, and too often, consumers and their families are the ones who end up with the responsibility to make their own connections and share their own data across these silos. And people, especially people with serious behavioral health illnesses, really need their care to be coordinated. Alice gave some examples of why that has been true in her case. From the research, we know that 2/3 of adults with mental illness have chronic physical conditions. 1 in 5 has a co-occurring substance use disorder. And people with serious mental illnesses and substance use disorders die between 20 and 25 years sooner than people without these conditions, mostly not from their mental illness or their substance use disorder, but because of those co-occurring physical health care conditions. Now, as Cara said, and as many of you are aware, the Medi-Cal program is tackling some of the thorniest of these longstanding issues that make it hard for the different systems to integrate, to provide adequate access, measure quality, maintain providers, and integrate care. Department of Healthcare Services Medi-Cal Healthier California for All proposal, released under the name CalAIM back in October, proposed a major transformation of the Medi-Cal program. A number of the proposals deal with the behavioral health systems, what managed care plans do, what county mental health plans do, and what SUD programs do. And here are some of them up on the screen. Behavioral health proposals for payment reform, revisions to the current medical necessity definition, so essentially looking at what is the responsibility of a managed care plan versus a mental health plan, administrative behavioral health integration statewide, meaning that at the county level, there would be a single plan for both mental health and substance use disorder services, and several others. I'm not going to discuss them all in detail. Not all of them will necessarily move forward in the form we've seen them so far. They're all under discussion in a proposal that will continue to evolve throughout 2020. If you want to know more about them, there is a fact sheet in your packets and much more detail on the Department of Healthcare Services website. But the first few items on this list, payment reform, net medical necessity, and the substance use disorder and mental health integration, are really the building blocks for care transformation, really critically important to modernizing care, aligning data, and relieving provider and consumer burden. They wouldn't fundamentally change the system we have. They might move us from a trifurcated to a bifurcated system, which would be good, but physical health and specialty mental health are still proposed to remain separate. The other proposal, there's an extra one. The other proposal that I want to talk about very briefly is for full integration plans. And this is just, there's been one meeting so far to discuss this. But this would allow for the development of entities to manage all of the Medi-Cal benefit, physical health, specialty behavioral health, and dental services. Again, these discussions are just getting underway, and we're not going to talk in detail about the specifics of that proposal today, but we do hope the discussion that follows will provide some context, and we, again, encourage you to follow along with what's happening via the Department of Healthcare Services website and get your comments in and attend the meetings if you are able. So last thing, before I hand this over to the next speaker, I want to offer some working definitions for today because integration can and does mean a lot of different things to a lot of different people. At the top, single point of accountability is what we call the idea of a single entity with a responsibility for all administration and oversight of the full spectrum of needs. And that's essentially the full Medi-Cal benefit in this context. And it's essentially what's proposed in the full integration plan proposal. Under that global concept of integration, though, is where we're going to be spending a lot of our time today, and it really is where the hardest work is. There are three primary areas for integration: operational, financial, and clinical. And starting from the bottom on clinical, That's essentially what Alice was talking about earlier. It means that consumers experience the care they receive as being connected. Physical health providers know what behavioral health providers are doing and vice versa. It does not necessarily mean that everyone goes to a clinic where those services are co-located, although we increasingly do see that model both on the primary care and the mental health side. Most people don't need that kind of one-stop shop necessarily, but everyone needs their full care team to be able to see what all their prescriptions are. Moving up, financial integration means that across different systems, funding is arranged so that all the incentives point the same direction. For example, a primary care and a specialty substance use disorder provider are paid in ways that create incentives for both of them to keep people out of the hospital, and the opportunity to share in upside savings when a consumer is maintained successfully in lower-cost community-based recovery services. And operational integration, again, an example. It's that the business functions of managed care plans are shared. So instead of multiple 24-hour referral lines, for instance, being run by different organizations in the same locality, there's one place that consumers can go to get their questions answered and be pointed in the right direction for appropriate care. So, since I know I'll be asked, is it possible to integrate on one level but not all of them? It certainly is, and we have examples of that from all over the California safety net. But integration that is only on the clinical level without addressing financing and operations doesn't achieve as much, and that's a lesson we've seen from other states and that I think we've seen here locally too. So with that, I am pleased to stop and turn this over to Alison Hamlin, the president and CEO of the Center for Healthcare Strategies and an expert on integration programs across the U.S. in Medicaid programs. So, Alison.
Thank you, Catherine, and thank you to the California Healthcare Foundation for inviting me to join you all today at this briefing. As Catherine mentioned, my job here today is just to give you a sense of how these issues are playing out elsewhere around the country. California is not alone in thinking about these issues, and to some extent, it's a good place to be in. Other states have moved quicker in this instance on this topic, and that's not to say California's falling behind. Really, it's an opportunity to learn from, in some cases, mistakes that other states have made or things they wish they have done differently, and perhaps most importantly, to learn from kind of the collective insights that have emerged across the country as these transitions have been taking place. For those of you who don't know the Center for Healthcare Strategies, we are a nonprofit policy resource center that works nationally on improving health for low-income Americans. And our principal levers that we focus on for achieving that mission are through the Medicaid program. So here in California, it's Medi-Cal. Across the country, it's generally Medicaid. And we work with state officials in Medicaid agencies, their sister agencies, responsible for managing parts of the Medicaid benefit. We work with federal partners at CMS and other relevant agencies. And we work across the delivery system. So as you all know, this work is about collaboration and partnership, and many levers are held at the health plan level, at the health system level, and our work really involves bringing all of those systems or layers of the system together to advance our collective policy goals. And we're based in New Jersey, so it's always a nice excuse to come to California. So thank you for the invitation. Okay, so when we start talking about integration at the policy level, physical behavioral health integration at the policy level, the conversations tend to start with financial integration, meaning how at the state level are the systems of financing and oversight and management of these benefits organized. And generally speaking, over the last 10 years, there has been tremendous activity across the states to try and reduce or remove the financing silos that have generally existed from the origins of the Medicaid programs in most states. And these systems, as others have already described, can create disparate and sometimes competing and conflicting incentives and clear barriers to coordination. And an obvious one that we can all relate to is around data sharing. And when data lives in different systems and dollars come from different systems, it's just much harder to move the dollars and move the data to provide that coordinated care experience. And so many states have started their integration journeys at this level of financial integration, and they've generally looked to two major policy levers to try and achieve a more integrated financing system. Here in California and in most states across the country, Medicaid is delivered through managed care. I'll show you a map in a moment, but it's really just a handful of states at this point that don't provide their Medicaid benefits through managed care. And so managed care is an obvious place to look to as a lever to promote a more integrated financing system. For states that do not have a managed care system, many have looked to accountable care organizations as another platform to build off for financial integration. But I think the main thing I want to highlight here, and what I'll show you on the next slide, is the pace of activity here has really picked up. Over the last 10 years, for example, on the managed care side, we've gone from about 15 states that offered a comprehensive integrated benefit through managed care to about 30 states in that time frame. And so many states have moved in this direction. They're not flicking the switch overnight. These tend to be gradual, phased processes, but this is a place where we're seeing a tremendous amount of activity. So here's a map, and I was chuckling to myself on the plane that California is a red state on this map. Maybe the one map where that's the case. So I will just talk you through at a high level what this map represents. And it is showing you kind of a snapshot of where states currently stand in terms of how they organize their specialty behavioral health services. The blue colored states are states that generally through managed care have integrated the physical and behavioral health benefits, sometimes in combination with an ACO approach. And again, if a key takeaway here is that the number of blue states has grown dramatically on this map. So 5 years ago, there were far fewer blue states on this map than there are today. The gray states represent states that operate fee-for-service arrangements, and as I mentioned, those are becoming fewer in number. The red states, as in California, are states that separately carve out and manage behavioral health services, sometimes through managed care, a separate managed care system as in California, and sometimes through fee-for-service. States that are similar to California on this map include Pennsylvania and Michigan, for example, both of which have very strong county-based systems for managing separately the behavioral health benefit from the physical health benefit. I would note that historically I would have pointed to Washington as also in this group, but Washington is one of the states that has flipped to blue in this case in recent years, moving from that separately managed on a county or regional basis for behavioral health services and integrating those benefits into their comprehensive managed care contracts around the state. Lastly, I would note that a number of the states that are also colored red currently have announced plans to move to a comprehensive managed care arrangement. Those include Michigan, which recently announced, or in the last month or so, some plans to move in that direction, and North Carolina is another state that I would mention there. I also just want to highlight the yellow color on the map, which is generally in combination with other colors. And these are states that have designed specialty integrated plans. So some of you are familiar with the concept of a special needs plan, a managed care product that focuses on the needs of a specific population. And a number of states have opted to develop a special needs plan model for individuals with serious behavioral health needs. And often they do this in combination with broad behavioral health integration and managed care for the entire population, but recognizing that they want to continue to operate some sort of a specialty system that is integrated yet unique and leveraging specific expertise and capacity for individuals with more severe levels of need. So the million-dollar or billion-dollar question tends to be, so, what have we learned? I've mentioned that we have, a growing amount of experience across the states. How are these models working? Are they actually delivering on the promise of integrated care? And unfortunately, we don't know a ton yet. Most of these models, even though they've been rolled out, have been phased. The data take a long time to emerge in terms of evaluations, and honestly, not all states have really committed to full independent evaluations, which we would strongly encourage them to do. But we do have some early data, and I've highlighted here outcomes from 2 states for which we have evaluation data that's been published. The first is Arizona, which gets a lot of attention. They have a little more running experience with their integrated model than other states, and have generally been viewed as a state that's had a thoughtful approach to their integration strategy. So Mercer conducted an independent evaluation focused on adults with serious mental illness in Maricopa County, the Phoenix region, which was the first area to roll out an integrated managed care program some years ago. Bottom line, over 75% of all indicators showed improvement. Importantly, all measures of patient experience improved, and I'll give you a few examples. Individuals' rating of their health plan increased by 16%. Coordination of care improved by 14%. And shared decision-making increased by 61%. And so this is individuals reporting their experiences in an integrated model compared to their prior experience in a non-integrated model. Other measures also improved, including adult access to preventive and ambulatory health services, as well as some measures related to chronic disease care, including comprehensive diabetes care and medication management for asthma. Not all of the measures were positive. I think those are really important ones that did show positive outcomes. But notably, some of the hospital-related measures were mixed. On the favorable side, 30-day follow-up after hospitalization for mental illness increased by 10%, but inpatient utilization rates for the adult population with serious mental illness actually increased substantially, and there's a lot of interesting discussion about what might be driving that. Is that identification of unmet needs? Not sure. So the second example I want to highlight is Washington State. Again, Washington is a state that historically has looked a lot like California in terms of the organization of the system. So in this case, the state agency conducted an evaluation of the first geographic region within the state to implement an integrated managed care model, and they looked at health and social outcomes for all Medicaid enrollees, as well as subsets of the population, including adults with serious mental illness and adults with co-occurring mental illness and SUD, and looked at changes year over year in outcomes compared to other states that had not rolled out an integrated model. And as noted on the slide here, again, similar to the Arizona story, they saw significant improvements in access to care, including mental health treatment and ambulatory and preventive care. Also statistically significant results related to quality, coordination of care, excuse me, and other utilization metrics. So generally speaking, the data are still early, but the data that we have are suggestive that this can move in a positive direction. Oh, the last thing I want to point out here is really interestingly, and I don't think many of us would expect to see these types of outcomes so early, but if you see the last bullet on the slide here, they found statistically significant improvements in social measures such as homelessness and criminal justice interactions. So Washington has a really integrated data system where they can look at data across public systems, including not only Medicaid, but also criminal justice and publicly supported housing efforts. And so really interesting initial trends in those areas as well. Excuse me. Okay, so these are big policy changes to take on. And we've seen states be quite deliberative in their efforts to figure out what is the system that they want to move to. And it's not a one-size-fits-all answer. It largely depends on the system that you're moving from and the capacities that you have in your state and where you are best positioned to make changes sooner rather than later. So just to highlight a few of the key considerations in really planning for a move and a transition to a more integrated system. The first is selecting the platform for integration. And Catherine used the term single point of accountability, which is a great term for it. Who is going to be that single point of accountability? Generally speaking, as I mentioned, states with managed care delivery systems look to their managed care partners and their managed care platforms to house and serve as those single points of accountability. In states like California, you have two systems, right? You have an existing managed care system on the physical health side and a system on the behavioral health side. So, you technically have a choice. You could integrate behavioral health into the physical health plans, or you could integrate, did I say that wrong? Behavioral health into the physical health plans, or physical health into the county mental health plans, or some combination of both. And there are lots of factors to consider in making that decision: the capacity of the plans you have, the nature of the managed care markets that you operate, how many plans are in given regions, and how you want to think about individuals transitioning between systems as their needs change, right? And again, there's no one right answer that's been sort of the universal decision point for states across the country, but these are key things to think about as you make those decisions about where that integrated point of accountability should live. And as I mentioned on the map slide, many states have chosen kind of hybrid approaches, recognizing that there is a value to maintaining some specialization of expertise and capacity. A second key consideration relates to phasing. Huge state, California. These are massive system changes that have implications for consumers, for providers, for the stability of crisis response systems, and really important public systems overall. And so given the magnitude of these changes, many states have chosen to roll these types of changes out over time. Many have done this geographically. Many have done this by population. For example, starting with adults and moving kids into a new system or an integrated system later on, recognizing that there are population-specific needs and services to take into account. And in some cases, states have really looked to sort of the willing, sort of early movers to start first. So Washington State is an example that they said by over 5 years, we're going to be integrated across the state, but we're going to let each region choose as to whether they want to be an early adopter, a mid adopter, or a late adopter. A third big question is delegation. So states need to decide to what extent they will allow this single point of accountability to subcontract or delegate certain parts of the benefit to other partners. And again, the benefit here is that you bring in sources of expertise with really relevant knowledge and experience related to services and individual and population needs and sort of cross-sector issues. On the downside, you kind of don't want to go through all of this rigmarole and end up effectively with still a fragmented system, right, by having lots of delegation and subcontracting. So one example of a state that has tried to toe the line here effectively is Tennessee, which allows delegation but has really strong requirements for data integration, for co-location of staff by function, et cetera. So another key decision to make here. Just to hit a couple more, one critical piece is not how you're going to manage the non-Medicaid or Medi-Cal services and enrollees with behavioral health needs who are not, individuals with behavioral health needs who are not Medi-Cal enrollees. As you guys know, Medi-Cal is the bulk of the funding for behavioral health services, but other funding sources are really critical, and that's true across the states. And so you need to decide what's happening to sort of all the dollars, not just the Medi-Cal funded pieces. And finally, the last point is a point that I try to make whenever I have the opportunity to speak about integration, and that is remembering the population of individuals who are dually eligible for Medicare and Medicaid. Generally, within a population with serious mental illness, anywhere from 25 to 50% of the population, depending on the state, will be dually eligible. And so if we're talking about integrating physical and behavioral health benefits, we really need to be thinking about integrating the Medicare piece as well. So Catherine's slide with the various levers of the system is a really important one. And as much as financial integration is key to addressing some of the sort of major sources of barriers, it is not the only important level of integration, not the only thing that matters. Last year, with support from the California Healthcare Foundation and the Blue Shield of California Foundation, my colleagues and I explored the question by talking with physical and behavioral health providers across the country in states that had moved to integrated financing. What changed? Did it become easier to deliver integrated care? And our biggest takeaway from these interviews is that integrated financing is definitely helpful and in most cases necessary, but it's also not sufficient. And so this kind of busy graphic, which I think you have a copy of that may be easier to read in your slides, highlights some of the other strategies that are really important in combination with financial integration to really ensure that care delivery changes at the point of care and that individuals experience a different system. These include, for example, investments in data sharing infrastructure. Just because we take away barriers to data sharing, the data sharing isn't going to happen if we don't have good data sharing systems in place and capacities to actually capture and share data across systems. We also need really good quality measures, better measures of how care is being delivered and if it's being delivered in an integrated and person-centered way in order to measure and monitor and ensure accountability across the system. We need to change the way we pay for care, as Catherine highlighted. And we also need to address any other regulatory and licensing issues that can stand in the way of ensuring that care can be integrated at the clinical setting. So lastly, I just want to highlight a few points, and that is that, again, in our work, we've been able to talk to stakeholders across the country who have been involved in these evolutions to more integrated models. And by and large, what we have found is that at the end of the day, regardless of how the financing has been integrated or who has been tapped as the single point of accountability, ultimately, this work is about supporting new partnerships between plans and counties, between plans and other plans, between plans and providers, primary care, behavioral health providers, et cetera. And so, frankly, what we've decided to really spend some time focusing on, and we just released a paper that I think is in your packets, is sort of what supports effective partnerships, because at the end of the day, really, that's what this comes down to. And so just a few points to flag that are in that paper, if you have a chance to read that, are first and foremost, before we do anything else, we need to engage stakeholders early and often, and that's in all aspects of these policy design and implementation efforts. Then getting to those essential elements of effective partnerships, we've seen that joint ownership and sort of joint governance models make a really big difference. And that wasn't something that we were expecting in going out and doing these interviews, but to the extent we can encourage the creation of sort of new incentives across systems and sort of more shared ownership of the entities that have this single point of accountability, it really sort of fundamentally changes the game, particularly when providers are at the table as sort of business partners in those arrangements. And I would encourage you to read the paper for more detail there. It really is about marrying the expertise of both physical and behavioral health partners. And we've seen across the states, particularly as it comes to really engaging consumers in the process and understanding how these changes are going to affect providers and consumers, that in particular the behavioral health stakeholders in the community are key partners to make sure that those considerations are really at the table. It's so important to ensure a stable system transition. These are big changes that have profound effects for the systems overall, for providers, for consumers, and making sure that ensuring stability is really critical. And the last one is just ensuring adequate time for planning and implementation, because these things really do require very thoughtful approaches. So with that, I will turn it back to Catherine. Thank you.
Thank you, Alison, for the presentation. And I just want to call out Alison and her colleagues at the Center for Healthcare Strategies for their thought leadership in these issues over the years. So if I could have California panel come up to the stage, and I think there's stairs on both sides, so you can go either way. And while they're getting settled, a few things that really stand out to me from Alison's presentation is that really, there is no single magic bullet. There is no single way that we know is the right way to move toward integration. It is hard work, and it's always possible to do better. So we're looking forward to continuing to track outcomes from other states as we move along, and we'll continue to bring you that research as we have it. A lot of it, as Alison said, is new. At this stage, just a break to remind you that if you have questions here in the audience, it's a good time to start writing them down, because we will start taking Q&A after this panel. I'm very excited, speaking of hard work, to have these distinguished Californians to talk to us about the work that they have been doing on the ground. They are all engaged in their counties in efforts to integrate specialty mental health and/or substance use disorder benefits with physical health care at all the levels we talked about earlier: clinical, operational, financial. And in each case, they'll describe what they're trying to do, how it's working so far, and some of the challenges and successes that they've experienced to date. So we're going to start with Dr. Takashi Wada, who's the Vice President of Population Health for Inland Empire Health Plan, and Andy Grucci, Deputy Director of Community Behavioral Health and Recovery Services for San Bernardino County, who will talk about some of the work they're doing. And I'm going to stay up here and advance their slides as needed. So turn to you.
Great, thank you. So thank you, CHCF, for putting this on. And it's great to see so many people here with interest in this really important topic. So I'm going to talk a little bit about some of the work we've been doing through Inland Empire Health Plan in partnership with San Bernardino County Department of Behavioral Health. So why integrate? Prior speakers have already talked about this, so I'm going to go through this slide pretty quickly. But as mentioned, our current system leads to poor outcomes for some patients, with many unfortunately passing away decades earlier, often due to physical health conditions. Patients have to navigate multiple complex systems, siloed systems of care and financing that hinder treating all of a patient's health issues. Limited ability for providers to share patient information and to manage and track referrals, resulting in poor care coordination. In the Inland Empire, and this is from our own data, members who have an SMI, or severe mental illness, or substance use disorder diagnosis use twice as many emergency room and inpatient services compared to other IEHP members. And more recently, we ran some other data and found that about 40% of that same population did not see their primary care provider in the last 12 months. So here you have a population that has higher or greater numbers of chronic physical illnesses. They're utilizing the emergency room and getting hospitalized, and yet 40% had not seen their primary care physician in the last year. So this slide just graphically represents what we've been talking about in terms of some of the siloed funding and operational issues. Behavioral health through the counties, of course, have their funding for mental health services, as well as drug Medi-Cal. Through Inland Empire Health Plan, or the managed care side, we have funding for the physical health, and we're also responsible for what's considered mild to moderate mental health issues. We have providers on our side, of course, on the physical health side, and given the siloed funding streams and fragmented systems, we try to do as best as we can in terms of coordinating across. But with these sort of structural challenges, it does make things more difficult, resulting in fragmented members' experience, inconsistent care coordination, as well as higher costs and poorer outcomes. And so why now? Integration of physical and behavioral health have long been goals of both Inland Empire Health Plan and San Bernardino County Department of Behavioral Health. And I'll just take a quick moment to say I'm relatively new to Inland Empire Health Plan, so I do want to recognize and give credit to IEHP leadership who had been working on this long before I got here. Dr. Jennifer Clancy, Dr. Jennifer Sales, as well as Dr. Brad Gilbert, our consultants with Blue Sky, and of course with Department of Behavioral Health, their director, Dr. Veronica Kelly. DHCS's Medi-Cal Healthier California for All, or CalAIM, initiatives does envision an integrated future. I think we've all heard about the great benefits of integration, both at the financial, operational, and clinical levels. But through Medi-Cal, Healthier California for All, some of those full integration proposals are not likely to be put forward for another several years. And so, looking at what we can do locally, there's great benefit already in terms of clinical integration and some things that we can control at the local level that will have benefits for our population. So we have been working on this for a good amount of time and hope to continue with that momentum while CalAIM or Medi-Cal Healthier California is still progressing along their timeline. And so with that, I'm going to pass it over to Andy to talk a little bit more specifically about what we're doing here in the San Bernardino area.
Thank you, Takashi. Roughly about a year ago, the leadership of San Bernardino County Department of Behavioral Health and Inland Empire Health Plan began talking and discussing the upcoming movement and integration in services. We had long been partnering since before 2014, particularly with ACA expansion and Medi-Cal expansion, working with the new tier system for mild to moderate and severe, working on agreements, assessment processes. And then we've also been meeting and talking about our struggles and concerns about that model. And so this seemed like a really natural step when we decided in April to pull together as leadership and discuss this. And we were originally focused on the moderate and the severe and that level, and asking the question, how do you determine a high moderate from a low severe? And how do you do the assessments and bring uniformity to that? And we quickly moved through these talks and really looked at, well, integration is going to be very important to the success of this as well. And partially, some of that came from, we were working with IEHP as a department and a provider for doing health homes in 4 of our large community clinics, and realizing the benefit of that type of collaboration, that care navigation of that model. So we began saying what would be our goals to reach for, what we were looking at, and to fully integrate physical and behavioral health, and what would that look like? What would the financial model look like? How would that look, considering we got our separate entities? Where at San Bernardino County Department of Behavioral Health is the mental health plan that's financed for that Medi-Cal, and also the organized system of delivery for the drug Medi-Cal. And then IEHP having the managed care responsibilities for physical and mild to moderate. One thing we wanted to do was outline and have a strong evaluation component, not just outcomes of what happened, but an evaluation component to document what we did and why we made our decisions and the way we made our decisions, and looked at how we got to what our model will eventually be. We formed work groups with IEHP and back at DBH with separate groups of consumers and separate groups of staff, focusing on financing, communication, service delivery, and also research and evaluation. Then those groups come together and discuss the different items and things we need to do to pull the project together. So the teams met separately at first, and then we began in late summer starting to move some of those teams together with DBH and IEHP. So the integration model and the care delivery we're looking at now is we chose 2 clinics in our county to have this model planned for. Both clinics offer mental health services and substance abuse services in them, and including case management services. We're looking at on-site primary care providers who will be integrated as part of the care team, and they will closely manage the patient's care in participation with the behavioral health providers. So part of what we are looking at is how do you, we do some integration with our county hospital outpatient primary care clinics where we have behavioral health providers in their clinic, primary care clinics. We're looking to see how would a model of bringing primary care services into the specialty mental health clinic, and what would that model, what would that take to do? We're also looking at standardizing our referral processes and improving on our case management care coordination teams at each clinic to serve the SMI population with chronic health conditions and high utilizations of emergency rooms and hospitalizations. So some of the key integration issues is first was addressing the different organizational cultures, stakeholders, and leaderships. We literally were not talking the same language. So mental health plans, doing especially mental health, we've kind of lived in that world since 1995, I'm going to say, and separate, and have not lived or really discussed managed care and the language for that. So there was a lot of times where we had to discuss what it was we meant by what we were saying, because there were instances where one thing was said and it was interpreted differently. And so the language and the cultural issues are something that have to really be addressed and looked at. And there were aha moments like a month later. Oh, this is what they meant. So that was very important. Also for us, working with stakeholders and the leadership in the county, our Board of Supervisors. Fortunately for San Bernardino County, our Board of Supervisors, 2 of our Board of Supervisors are also on IEHP's governing board. And so that makes it easy to make sure we message to them and to the constituents and to our consumers, but also other stakeholders for our county mental health plan, which is a safety net plan, is our regional medical centers, our public health department, our Department of Aging and Adult Services, Children's Services, our sheriffs and law enforcement agencies, and our probation departments, that as a department, county department, we're involved with a lot of shared programs with those agencies. So one of the things we looked at was sharing data and model utilization and project cost. And the sharing of data is a big hurdle, as some of the other presentations showed, due to the administrative and the financing models. Some of the rules and regulations around confidentiality, 42 CFR on the substance abuse side is really a major hurdle to address, to be able to share information and get better outcomes and look at utilization. We also are designing this model to estimate what the costs are. And so we're really looking at not really knowing what will be the cost and the utilizations, what would be the paneling for primary care to have this type of population. We've looked at financing models to see how the financing would flow. We've talked about different ways of doing it. We have the ability right now as our county agency to be able to contract, say, with IEHP for that, and then to be able to have IEHP contract back with us to try to see if there's a way that we can manage this one administrative flow of financing. One of the key other things in integration that we learned was that IEHP is a managed care organization, and their responsibilities to the state was that they had several measures and outcomes of their accountability that was really dependent on what our department was doing. And without the ability to share that information with them, without that ability to plan services with what their accountabilities are, it was really leaving at a disadvantage for them to be able to share what their outcomes were, but to overall improve the health care of the system for our beneficiaries.
Thank you so much, Andy and Takashi. We're going to move now to hear from a different part of the state, from Margaret Kisliuk with Partnership Health Plan of California. And Margaret is the Behavioral Health Administrator at Partnership and is going to speak about Partnership's work with 8 of their 14 contracted counties to develop the regional drug Medi-Cal organized delivery system model, it's a mouthful, in which the managed care plan is going to manage the substance use disorder Medi-Cal benefit on those counties' behalf. So, Margaret?
Thank you, Catherine. I want to start by providing a little bit of background on Partnership Health Plan and why there's several reasons why I feel really fortunate to be able to be talking about behavioral health integration with you at a time when behavioral health integration is being discussed so widely. Partnership Health Plan has had the leadership and the interest in doing this, and some of the examples of that are when the mild to moderate benefit started in 2014, it's been the big push of Partnership to make sure that our members utilize this benefit. Our penetration rate is 8 to 9% within the behavioral health system. And in addition to that, about 10% of our members also get mental health services from their primary care providers. I'm also fortunate because Partnership, in our 14 counties, we have some of the strong, very strong, I don't want to say strongest since I don't know everybody, but we have some pretty strong and innovative federally qualified health centers. We're very heavily dependent on these centers. They provide over 75% of our care, and they started integrating behavioral health services long before this was a discussion level, at the state level. We've been working very closely with our clinics to try to expand the use of medication-assisted treatment. I should mention that for the most of the 14 counties in Partnership Health Plan, particularly the ones that are involved in the drug Medi-Cal model, are very rural. They have among the highest rates of addiction-related deaths in the state. Some of them are very low on the county health scores and high rates of suicide and mental health issues. So this is clearly an issue where county leadership is key, and we have some pretty innovative county leadership within our system. So we've been encouraging our primary care providers and others to provide medication-assisted treatment, not only for opioid abuse, but also for alcohol abuse. We've been working very much. The other reason I'm fortunate is that we've yet to implement our drug Medi-Cal plan, so I can claim pretty much anything, and I won't have to prove it yet. But while we've been waiting to get drug Medi-Cal off the ground, we have been working with our entire 14-county network to try to strengthen addiction-informed care in all of our settings. We've provided trainings for our primary care network in how to treat alcoholism in the primary care setting, management of benzodiazepines, addressing marijuana among those who are pregnant, and we've also been working to try to with our hospitals to utilize the voluntary inpatient detox benefit and to try to foster the relationships that would encourage them to work together. Anecdotally, we know that a high proportion of those seen in our mental health system also have addiction issues, so we've provided trainings for our mental health providers on co-occurring disorders. So, when the waiver rolled out, and this is in 2015, making it county option to offer the organized delivery system benefit, 8 of our counties came to us and said, we don't want this benefit separate. We want an integrated system. You guys know managed care. We don't want to set up a whole new managed care system, and we want the clinics to be part of the network. So can you do this for us? So we've been working with our counties, with these 8 counties, and with the state to try to roll out the system for several years. And I think we're almost there, but as I told Catherine, I would have said that a month ago, but it does seem like we're almost there. We're waiting for a federal approval, and we all know how much fun that is. So one of the biggest barriers for management of the integration at the plan level was the different ways these systems are funded. The county systems are funded with realignment dollars that go to the county, and then they draw down the federal match. We are funded very differently within the managed care setting. So what we ended up was a capitated rate based on per utilizer per month that we would charge each county. They would use that rate to pull down the federal dollars, because only the counties can do that. And then eventually we'll reconcile it all back to costs, so it all fits into the short Doyle system. This, I summarized that in about a teeny percentage of the time it came to develop this, and it was pretty arduous for our financial staff, the county staff, the state staff, and I'm glad to say we at least have reached the model. How the model works is that it's no wrong door, as in all counties. It's the ASAM criteria that would determine the level of care, and we're going to be working with key county agencies that are not usually part of the managed care discussion, the criminal justice and child welfare, to make sure that they're integral parts of our system. We want to serve clients in their communities as much as possible, even in these rural areas where there's not a lot of resources. So we're going to focus very much on peer-to-peer services and case management and other ways to link members back to the outpatient services if they have to go out of county for residential other services. And then one of the big pieces that we will be working on after we go live is how we build the system, the pieces of the system that aren't quite there because neither system really allows for them without a lot of work across lines. For instance, clinically observed detox. It happens every day in emergency rooms. We'd like it to happen in a way that's better for clients and that works in our settings. And that's not something that's clearly allowed in either model. So it's exciting time for us. I think we've figured out a way to do this, but my hope is that years from now it'll be easier. Thanks.
Thanks, Margaret, and thanks for your leadership on this issue. I know it's been still is a long haul to make those dollars work. Our final presentation is from two representatives from San Mateo County. Louise Rogers is the chief, and Scott Gilman is the director of Behavioral Health and Recovery Services for San Mateo County Health. And they're going to talk about how they are figuring out, working with their local health plan, the Health Plan of San Mateo, how best to integrate operationally. So,
good afternoon, everyone. I'm Louise Rogers, Chief of San Mateo County Health, and welcome Scott Gilman here, Director of Behavioral Health and Recovery Services. And as Catherine said, in San Mateo County, we're really anchored in this partnership that we've had with the Health Plan of San Mateo for 30 years at least. And as we look forward to where we'd like to go next in terms of integrated care, we really think of that partnership as being one of the key aspects that enables us to move forward. So before we talk about those opportunities and what we're excited about under the next waiver, I just want to say a little bit about who we are. Oh, you have switched the slides. So San Mateo County is a medium-sized county, and I think the important things to know about us are that we, although we're a relatively affluent county, we interact with about 100,000 residents in our health system. And the system that I operate is a system that contains a hospital and clinics, behavioral health, correctional health, public health, aging and adult services. We have hundreds of contractors. It's a medium-sized county with a fairly complex system. And we have been partnering with the Health Plan of San Mateo, as I said, for some time. And they are really a publicly accountable county organized health system. And by that I mean really the governance for the Health Plan of San Mateo includes two of our board members, our county manager. There are a number of people on the health plan board who are directly connected to the county. And they have always had a very, very public mission. They have 130,000 Medi-Cal and Medicare members. We have contracted with them to cover people who are uninsured in the county. And we've had many business relationships with the health plan that support our ability to really do county work, including managing our pharmacy benefits and that kind of thing. And San Mateo County's always been a place where it's a little easier to try new things, a little easier to get things done because we are a medium-sized county. And so, for example, in the 90s, we were the only behavioral health system, the only mental health system in the state of California that piloted a case rate reimbursement system under Medicaid. And that was great, and we would have been delighted to continue in that model forevermore, but the state required us to shift into short dwell Medi-Cal because none of the other counties really were interested in doing that. So in order to understand where we'd like to go, it's important to note just a couple of things about our partnership with the Health Plan of San Mateo and how it's evolved over time in really three different areas. And Scott will handle the first.
So I arrived in San Mateo about this time last year from Michigan and found that the division that I work for, Behavioral Health and Recovery Services, was not only performing all of our mental health plan responsibilities for the SMI population, but we were also managing that line of business for Health Plan of San Mateo. So essentially, we were managing the mild and moderate benefit. The issue with that is we were out to our eyebrows in trying to meet all of the new managed care regulations, NCQA regulations, and so it's been extremely challenging for us.
The other area where we've really partnered with the health plan and seen a lot of benefits is providing care coordination for high needs beneficiaries. In the children's arena, through the whole child model, we've really been the boots on the ground care managers for the health plan's benefit for California Children's Services and kids on Medi-Cal who have the highest needs, including embedding our staff in the health plan of San Mateo physically so that they could operate in very tight coordination to coordinate care for those beneficiaries. Also in aging and adult services, we have similarly embedded staff in the health plan of San Mateo to be care coordinators for something we call Partners for Independence. And there again, we're really leveraging our public partnerships, the knowledge that we have as a safety net, in this case for older adults, to again be the boots on the ground care coordination for those members. And many of those members are IHSS beneficiaries as well. And then thirdly, the whole person care initiatives have been a great opportunity for us to develop that care coordination function for people who are co-occurring mentally ill and struggling with addictions. And then the third area, which is actually less of our focus today, but just to acknowledge that we've been very, very focused on primary care behavioral health integration in clinical settings, both providing consultation within primary care from behavioral health and embedding nurse practitioners in our specialty behavioral health settings. And our focus is really shifting now, and hopefully through the next waiver, to more integration strategies for our back-end managed care functions. And that's because we're really hitting the limit in terms of what we can do in the delivery system in terms of integration when the back-end requirements are so siloed. It's forced us to realize that we can only get so far if we don't take a look at integrating those back-end functions. So where we're interested in going in the future is continuing to work on the delivery system reforms, such as through whole person care, but really trying to revisit this enormous burden of the back-end operational requirements that we see are really challenging our ability to deliver a seamless experience for our patients. And one of the main examples of that is these siloed information systems that really sit on siloed requirements. And that made it very, very difficult for even care coordinators and care partners to actually deliver integrated care or coordinated care because the information systems are so separate and siloed.
So again, just living in the Michigan world, which is a heavily managed, heavily regulated operation, and we were subcapitated, so we had lived under the final rule for managed care that we're starting to gear up for. I really saw that what I was going to have to do at our operations was going to require a lot of resources, a lot of investment in time to really develop the sort of robust back-end services that we were going to need: claims processing, IT, software, even developing some of the processes that are going to be required, conflict-free case management. The list goes on, and so it's a very, very heavy lift as we move forward. And having lived in that world for 30 years, as CEO the last 13 years, we decided to start to have this discussion.
And we want to guide this revisiting of who does what with some key questions. So the first is really, are the managed care functions that we are both doing, the county and the health plan of San Mateo, are they both really adding value to our patients' experience? And so just as an example, do we both really need to run 1-800 numbers and access teams, that sort of thing? A second question is, what are our core competencies? And where do we most bring value to our patients' experience? What are we strongest in, and how can we leverage our strengths?
Exactly. As Louise mentioned, that's really what we've struggled with in Michigan when we went through several iterations of this. Is, as the public behavioral health care system, do we really want to focus in on being a delivery system, which we do really well? We know our communities, we interact with law enforcement, we know our populations, or do we want to invest our time and resources in more of the back end? So we really believe that infrastructure needs to be built, and there's core competencies that we both bring to the table.
So we've engaged some consultants to assist us as we think through some of this. And one of the things that we've learned, and actually I think it comes through the CHCF report as well, is that there's actually a lot more that we could be doing even under the current waiver and requirements. And so we're asking ourselves, does it make sense to contract with the health plan to carry out some of the managed care functions really on our behalf, as we have historically for uninsured and pharmacy and other things? Is there more that we could do even under the current state? We recognize that there are limits to the benefits that will achieve for the delivery system and for patient care. And ultimately, it may be more helpful to do those things, but drive towards a system where the requirements themselves are more integrated. So we're looking now at how can we take some interim steps, but our hope is that there'll be more opportunity in the future to have a more seamless experience. And the goals that we want to achieve are really primarily related to the beneficiary's experience, reducing complexity and the need to navigate multiple systems. What Alice talked about a beneficiary being able to really have an integrated experience in interacting with her providers and developing a shared plan it seems critical. Improving provider experience by reducing complexity and the need to navigate multiple systems. So thinking about things like contracts and network administration and claims payment. Do all of these things have to be done multiple times when the same providers are actually involved? And then aligning funding, data reporting, quality, and infrastructure mainly to be incentivizing common goals across physical, mental health, and substance use care. And then it's very important to maintain accountability. That's not something we're highly concerned about. As I mentioned, we have really, the governance is highly shared. And our health plan has been on the cutting edge of maximizing benefit for low-income residents, partnering with us, for example, to make housing more accessible for our beneficiaries, but looking at that accountability and particularly what are the measures of that improved experience for beneficiaries. So those are some of the things that we're thinking about as we try to move forward in this direction. Thank you.
Thank you, Louise and Scott, and thanks to all the panelists. We are going to move right into questions. I'm still getting some, but I'll just ask the first one while Alison and Alice come back up to the stage and to join the panel. Curious, and this is for the county folks, whether you have or whether you see a way to use some of the other dollars that are part of the public mental health system, and specifically MHSA dollars and innovation dollars, to support this process of innovation and integration. Maybe Andy?
I'll take. Yeah,
Okay.
we're discussing using our MHSA dollars to help with some of the cost and funding of the integration pilots, because largely what our pilot wants to do is explore what would the costs and what would be the model of financing for this type of population, this type of service. So we're looking at how our MHSA dollars are used and what they can be used for. Really hoping that we can utilize some of that in these programs to take care of that. So.
Thanks.
I'll just add that we have already partnered with the health plan of San Mateo around, for example, intergovernmental transfers that lean on our MHSA expenditures. So I think we have a long track record of doing that kind of leveraging and would look forward to continuing that.
Thanks. And related to that, I think, a number of you, I think, have experience with addressing the other parts of the system, since we were just talking about MHSA, but obviously the public mental health system is more than Medi-Cal, and I'm curious how you have thought about maintaining those other pieces that are not necessarily part of the Medi-Cal specific benefit that we're discussing here.
Well, the main thing that I want to point out is that we're directing enormous resources into administration of the Medi-Cal program and an increasing higher and higher burden. And to the extent that we can operate in a more efficient manner by consolidating some of our functions, it really liberates resources to do the things that in counties we are always going to have to do. And it liberates resources to allow us to do more of that. So for those folks that are complex and co-occurring and homeless, where we're doing street and field medicine, I feel like the more we can stretch our resources to be able to do more of that, it's going to benefit the population we serve.
So our pilot is taking a look at just what we call our community mental health clinics and the integration on that. County mental health plans are the safety net for counties, and we have a lot of scope and other services that we do besides what might just commonly be thought as outpatient treatment services and that. And like, for example, if you take crisis services, so our department operates mobile crisis response teams in 4 regions of our county that operate 7 days a week, almost 24 hours a day. We have 3 urgent care crisis walk-in centers, and these programs are open to anybody in the county, not limited to Medi-Cal beneficiaries. We also have 2 crisis stabilization units, which are unique that they're voluntary and not involuntary units. And we also have 5 crisis residential treatment facilities for a total of 62 beds altogether. And these programs, we look at them, but how they would work in terms of integration, in terms of both the financial and the clinical piece, almost at times leads to that the crisis service parts would almost be like a standalone due to their scope and their safety net service that they provide, and not just being dedicated to the Medi-Cal population.
Thanks. Margaret, a question that comes, I think, to you is, how can integration really work in a system that is segmented by county, especially in regard to SUD, in which often it is necessary or can be beneficial to leave your county residents for treatment? I think that's some of what you're trying to do, but maybe you can speak a little bit more to that outside of partnership.
It takes a lot of work. Our counties, right now, in some of our counties, they can move, our members can move across the counties for services, and it's not so much of a barrier. We also are fortunate in that, particularly our northern counties have a long history of working closely together and are accustomed to sending folks out of county for certain services, but especially because of the financing model that we're charging the county of residents for the services this member gets regardless of where they get them. It'll be a continuing discussion about, and that's where we're going to be relying on case managers and peer support to try to make sure that the system brings folks home when we can get them home. But it's been a work in progress. One thing I didn't mention, I'll just mention quickly, is 3 of our counties already are operating the organized delivery system themselves. So we're already road testing, trying to figure out a way to make things work more smoothly. And the best I can say is it's a lot of communication and trying not to drop the ball when members need care.
Thanks. We got a couple of questions about technology, and in particular, and this people could answer from their current experience, or Scott, I don't know whether you have experience, about the use of telehealth, and particularly telepsychiatry, in helping to integrate care. I don't know whether you or others have a comment on that.
Well, we are using telehealth for psychiatry, and actually we just used some one-time funding that we had to even expand that even more so that we have it available. Our approach is a little bit cautious in that we make sure that there's always a clinician at the site with the person, even if it's in the field. I think that's required. But other than that, all across the system, we're using the telehealth.
Okay. And Alice, I don't know whether you have any experience from the CIBHS side about the use of technology from the consumer perspective? Okay. Margaret, were you going to jump in?
I was just going to say, because of our far northern rural counties, we have a heavy investment in telehealth for a variety of services, not just for behavioral health, and many of our counties use it as well. We can provide services in the home or in the clinic, depending on what the nature of the services are for those members that want them and have broadband.
Thanks. Alison, a couple national questions. A lot of interest in integrated data systems across states. We're a little jealous, I think, of what you described from Washington and Tennessee. Any insights on how that process was managed and paid for?
Great question. My short answer is I have good people to introduce you to in those states if you want to talk more. So find me after the panel, and happy to do that. I would say this is an area where we're seeing a lot of state interest in better connecting those systems across service lines and financing lines. And from a policy perspective, it's invaluable, right? Because you can answer questions like, what happens to the criminal justice system when we reduce funding for mental health or SUD treatment services, or vice versa. And we all know that all of these systems are codependent and rely on one another. And when you squeeze one side of the balloon, the other side increases and so forth. And when we have the data that can help us evaluate policy questions like that in a more cross-system way, it's quite enabling of sort of more holistic policy making overall. So it's an area at the state level that we're seeing happen more and more. And again, can talk more about that offline. And then that same issue percolates down to the county level and the health system and provider level as well. So they're complicated questions, but there are success stories. And there are ways to use enhanced federal match from the federal government from a Medicaid perspective to, is that not working?
Not as well.
Sorry about that. The last thing is just that there are opportunities for states to garner enhanced federal match to support those investments, and there are great examples of that happening around the country as well.
Thanks. So the end of our time is drawing near, so I'm going to take the prerogative to ask very quickly for little tiny bullet point answers. What do you need in the work that you're doing in the counties? What do you need from the consumer perspective in terms of state leadership to help move along in what you're doing? And everyone doesn't have to answer, but do any of you have thoughts on that? Louise?
Well, I'm really hoping for some flexibility for counties and plans to move forward the options that make the most sense locally. And so in the next phase of work, California can learn even more about what it takes to deliver integrated care through different models.
Go ahead, Scott.
Yeah, I also think I'm hopeful that we can get more state leadership in dealing with the difference between the SUD system and the MI system. We're implementing the SUD system, and coming from the outside world, doesn't make any sense at all. At all.
Okay, one more. How about Takashi?
Sure. I would just add in data sharing. We've talked about it a little bit, but really accurate, timely, integrated, and actionable data is foundational to any type of population health management program. And so we just recently started doing that, but we do know that counties interpret some of the privacy rules differently. And so some state guidance or recommendations around that I think would be helpful, because that's really where we're going to see a lot of the benefits when we can get back gaps in care reports. We can identify social determinants of health to maximize coverage of services under the new waiver. And I think that way we can certainly share information and for care coordination in a much more effective way.
Thanks. And Alice?
I think one of the things that I would like to see is really having state leadership look at prevention and really understanding what prevention is and make sure that prevention doesn't lead to unhealthy outcomes. So sometimes you can educate a consumer to the point where they are themselves preventing things, and yet you have to make sure your system is not harming you in that preventive care. So really looking at how preventive care really works from the consumer perspective. The other piece is really educating a consumer about their own body and how it works and really what they can do to prevent harm and maximize their wellness. I think one of the things that I've done over the years is really become educated about how my body works and what I'm doing to it and what other people are doing to it and how to prevent that harm and to maintain wellness.
Thank you. Well, obviously, there's much more to discuss here than we could do justice to in 90 minutes. If you have ideas for what else you'd like to see discussed in a forum like this, please take a minute to note that in your evaluation, and please do fill out that evaluation. We rely on your feedback to help us plan these events. In closing, I want to thank my colleagues at CHCF, particularly Danny Sandoval and Crystal Haswell of our Sacramento office, who took this briefing from idea to reality. And I want to thank Golden State Health Policy and the team from Metro Media, who handled the logistics. And thank you to our wonderful ASL interpreters. We're glad to have them here. We want to thank especially our panel from near and far for their willingness to join and share their challenges and uncertainties, along with the successes. We appreciate all the work you do for California consumers. And with that, it's a wrap, and thank you again for coming.